November 2025 with a history of headache and progressive loss of vision in right eye, followed by a squint of the right eye as well. All this for just 3 months. He presented to us with in a completely awake, alert-oriented state, absolute vision loss in right eye, and now he has been having this blurring of vision for past week in the remaining left eye as well, but he's still able to read. Right side is completely in terms of vision, it is lost. However, it has right abducens palsy as well. No other deficits are present. Trigeminal, facial, everything else is okay. The MRI brain at that time showed a large aggressive skull-based tumor, confirmed with CT that it's a destructive clival-centered skull-based mass. So we recommended a transnasal biopsy first to look at the pathology. The first biopsy was done in December when it was about 2 months of symptom onset, and that came out to be a fibro-osseous lesion without any features of malignancy. So we advised them to repeat another biopsy, but the results of that biopsy are exactly the same. And now patient has been having progressive vision loss in the only functioning eye, and we have nothing in the 2 consecutive biopsies. The question to the board is for further plans. I'll move on to the scans now. Scans मैं बता दूं या we have
We can
already
ask Dr. Shumaila. Yeah. Dr. So Nasser, we have Dr. Shumaila. We can ask her.
All right.
जी अस्सलाम वालेकुम.
If you want any other sequence, any other view, let me know. I'll put it right away.
Okay.
Thank you.
So we have a slide of T2 weighted axial images, and we can appreciate that there is a T2 hyperintense lobulated lesion centered in the midline in the region of clivus, and it is partially encasing bilateral ICA. It is showing extension anteriorly in the paranasal sinuses. If we go to the next slide on sagittal images, so I can appreciate that there is an abnormal signal intensity area, but it is well corticated. It is causing mass effect on the brainstem, pons, midbrain, but still it has well-defined margins. It is showing peripheral enhancement, and same is appreciated on the next set of images, which are coronal. I would like to move on to the CT images. And on CT scan axial bone window images, I can appreciate that there is a focal lytic expensile lesion. More or less, the lesion has well-defined margins. So I was just thinking of, since I knew the histopathology, I was just thinking that can it be some kind of fibrous dysplasia, benign bony lesion, which is expensile, causing compression on neural foramina and rest of the structures, but it is centered in the midline on clivus. So that was the thought which was coming to my mind after looking at the CT images and after, because I knew the histopathology. It is partly centered on the clivus. It is going interiorly as well, but it's all over. Its cortical surface is intact, more or less. Especially when you look at these sagittal set of images, I can appreciate that the cortex is intact everywhere. So it is probably some benign bony lesion, and as the histopathology already reveals that it is a fibro-osseous lesions, I was thinking in lines of fibrous dysplasia.
Can you ask if there's any soft tissue ossification at all?
When I look at the images, the post-contrast T1 weighted images, there is peripheral wall enhancement, but probably that can come in fibrous dysplasia as well, because it is like the characteristics of lesions are more evident since it's a bony lesion, so they are better depicted on CT images instead of MR, because on MR the calcifications, they are not that, the picture is not that clear in case of, for example, if I see a fibrous dysplasia in a limb, so I need an X-ray or a CT to confirm my bony details. So probably it is some kind of fibrous dysplasia. It does not look like a chordoma. When we look at the sagittal T1 post-contrast images, there is no central enhancement. The enhancement is only along the periphery. And that is probably the fibrous and the osseous, because the fibrous scars, they also enhance. So the fibrous component is going to show enhancement.
So my question was whether there's any possibility it could be a base of skull osteosarcoma if there is soft tissue ossification.
Actually, the osteosarcomas, they have they have bony spicules, a lot of bony spicules, because they have a lot of osteoid material. Now they are osteosarcomas, so the osteoid material should be too much on CT as well, but it does not look like an osteosarcoma. There is not too much osteoid material. Any other question?
No, I think we can.
So, Nasser, do we have the histopathology report with us?
Yes, sir, that's what I'm sharing right now. Can you see it on the screen now?
जी जी
Yes,
आ रही
yes.
है जी.
So nothing much here, just vascular stoma and myofibroblastic proliferation.
अच्छा, और नसर ये सेकंड बायोप्सी भी एंडोनेजल ली थी?
जी सर, दोनों बायोप्सीज एंडोनेजल हैं.
ओके.
So, Dr. Nasser, did you get a chance to
And
discuss that?
I'm showing the first biopsy report as well, which has a little more details because there were two specimens sent on this one. One was soft tissue and one was osseous. So I'm gonna share that as well. सर आप कुछ कह रहे थे?
आई थिंक डॉक्टर आसिम कुछ पूछ रहे थे.
Dr. Sir, I कह रहा था कि did you get a chance to actually discuss with your histopathologist? Because looking at the scan and what Dr. Shumala actually explained the features, it is could be something like fibrous dysplasia. Because two-time biopsy didn't show any malignant component. Because the important thing is that all management depends upon the histopathological diagnosis. Because if we are considering the fibrous dysplasia, the management is simply the surgical excision or the conservative management. However, if we are talking about the other way around, then definitely the oncological input is definitely required over there.
Yes, sir, we did discuss it in our MDT as well a couple of times, and each time histopathologist was present, and they were also of the opinion that this could be fibrous dysplasia, but they were sure that there was no malignancy involved in here.
Okay. So if there is no malignant and the patient ki symptoms is of vision loss, right?
Yes, sir. He has complete loss of right eye, and now for last 3 months he has been having this left eye progressive visual loss as well.
इसमें कोई बोन स्कैन का रोल होगा? अगर मल्टीपल होंगे तो आपको किसी और जगह भी मिल जाएंगे.
Good point.
Because fibrous dysplasias में multiplicity होती है, so if you can get a bone scan, तो उसमें आपको किसी और जगह भी मिलता है, that is going to further strengthen your diagnosis. Decompression तो ज़ाहिर करनी पड़ेगी क्योंकि patient symptomatic है, वो तो जो भी है, but एक road map मिल जाएगा कि अच्छा भाई this is a benign lesion and how we have to approach this.
I guess
Right, because
given the progressive symptoms, they'll need decompression anyway, and decompression will give you more tissue and probably will get a better histological diagnosis.
And bone scan, sir, bone scan करवा लें पहले.
I'm not sure bone scan is going to contribute because the local treatment is needed anyway. You can't really, given that there's progressive visual loss, you can't really wait for biopsying another site and then waiting for it and then come back. I would have thought that local treatment is needed anyway.
Right, right. I think that what Dr. Shumaila is pointing out is maybe towards the prognosis, and then he can.
Yeah, I think a
Right, so
PET would be a better option than a bone scan if you're going to do anything.
Okay. Dr. Asim, sir.
Doctor Hassan, I completely agree with Dr. Saeed regarding because depending on the patient symptoms, definitely decompression is required. So it should be the first step. Definitely the other factor definitely contribute in the diagnosis process. So yes, one can actually go for the PET scan and see how it actually shows the other lesion if there is any to be shown. But the important thing is that at least because the patient weight is compromising, I think the compression decompression should be the first step. The one thing, and it also contribute to the more tissue for a better histopathological diagnosis.
Nasir, any other question you want to ask to the board? I
no, so
agree
I
with
guess
him.
that sums it up. We will just get the and refer for tumor resection.
आपकी आवाज साफ नहीं आई, sorry. Nasir, can you please repeat?
No, sir, I was just saying that this sums up it very well, and we are going to offer systemic scan and surgical resection.
Perfect. All the best. Thank you.
All right.
Thank you.
Okay, so now we go to the next case. Bilal, now you can share your screen. Dr. Shumaila, we have another case. I did not get this case last night, sorry, but we are adding, so that's why I could not send. But we can discuss
Okay.
briefly. And then the third one is the same that was shared with you.
Assalamu alaikum. Can you
Walaikum
hear
assalam,
me?
Dr. Munib. कैसे हैं आप सर?
जी अल्हम्दुलिल्लाह ठीक ठाक खैरियत से। अच्छा मेरा क्वेश्चन ये है, सारे केस मल्टीपल टाइम्स एमडीटी में डिस्कस हुआ था जो से डिस्कस किया है। फ्रॉम सर्जिकल पॉइंट ऑफ व्यू हाउ मच डिकम्प्रेशन कैन बी डन? ये मेरा सर्जन से क्वेश्चन है जस्ट फॉर माय नॉलेज।
I think decompression
ये
can
काफी
be
एक्सपेंसिव
done.
डिजीज है।
Decompression can be done, but if you're talking about gross total resection, वो challenging हो जाएगा और उसकी morbidity शायद ज़्यादा हो जाए. But I think decompression can be done जिससे कुछ symptoms उनके improve हो जाएंगे, and then I think we can get some decent local control इस तरह से. And depending upon the expertise of the center, one can go endonasal, even वो जो नीचे जो सारा clivus वाला है वो endoscopically भी decompress हो सकता है. But again, it's surgeon's choice कि वो कौन सा route use करता है. But decompression, I think, should be offered, and I feel like it will be beneficial. Significant decompression हो सकती है, gross total resection हो सकती है नहीं. It's difficult. I think there are many factors during the surgery perioperatively when we encounter neurovascular structures, and then some decisions are made that time. I think we have Dr. Irfan also, if he is listening. I think it would be great to have his opinion from surgery point of view. And we have a couple of other neurosurgeons also. I'm just now looking in the panel. If anybody wants to add. Okay. If
ठीक है जी
no,
सर, थैंक यू।
thank you, sir. Thank you. We go to the next case.
Assalamu alaikum, everyone. So I'm
Right.
presenting the case from Khan University. He's a 36-year-old male patient, right-handed, presented with focal seizures and slow response for 1 month. Past history is significant for right frontal craniotomy for third ventricle pilocytic astrocytoma in 2023. So the pre-op MRI done in December 2025. I would request our radiologist to kindly discuss the findings of the pre-op MRI.
So these are T2 weighted axial images, and I can appreciate that there is a focal abnormal treatment in mass lesion. seen in the right subfrontal and medial temporal region. There is a large cystic associated component, which probably appears to be dilated third ventricle or a cystic component of the mass lesion. I would like to clear that with the help of other sequences. So this is hypointense on T1, and this is, I think the first row is T1 plane, the second row is T1 post contrast. So it is around MCA, centered around right MCA territory. It is causing dilatation of third ventricle as well. It is now showing patchy post contrast enhancement in the region of subfrontal component and as well as in the medial temporal component. There is associated hydrocephalus. I can see plump right temporal horn. Go to the next slide, please. So there is enhancement which is more evident on these images. On the sagittal images, there are multiple ring-like and heterogeneous kind of enhancement in the solid component, and probably there is some encysted cystic component with this lesion as well. So there is associated vasogenic edema, and I think these are post-op. I can see craniotomy defect on the right side. These are not pre-op.
That was there is a history of surgery in 2023 as well.
So we will not call them pre-op because the surgery is already done. We do not have the images from 2023, right?
No.
So we do not know the basic appearance, MR appearance of the lesion pre-op, the actual pre-op, the first pre-op. So I don't know that how it appeared initially when it was labeled as astrocytoma, but currently there is increased bulk in the soft tissue. There is an enhancing mass. There is associated vasogenic edema in bilateral frontal lobes. So I'm not sure patient had some kind of radiotherapy as well at that time.
There is no history of radiotherapy.
Okay. So the third ventricle is ballooned. The lateral ventricles appear they are not that dilated. There is a soft tissue mass lesion, a neoplastic lesion. There is a craniotomy defect, and the lesion shows heterogeneous enhancement. So there is probably recurrence. I don't know how much was removed and how much.
And is there any biopsy from the first surgery,
Yes,
Dr. Bilal?
I think he said that there was pilocytic
Yes,
astrocytoma.
this was pilocytic astrocytoma.
Okay.
Yes.
Okay.
So the patient underwent an NG-guided right parasagittal craniotomy plus third ventricular cystic lesion resection and an NG-guided right temporal craniotomy plus lesion resection.
Okay, I just want to add one thing to the here, the panel. NNG here means neuro navigation guided. So it's just that's how we write that after the surgery or before even surgery. So neuro navigation guided. We use it to be precise. Thank you. We can proceed.
So this is a post-op MRI after second surgery.
So there is still residual soft tissue seen in the site of primary tumor. There are post-surgical changes. I can appreciate some air fluid levels, pneumocephalus secondary to surgery. And do we have post-contrast? So it was done in the first 24 hours post-op?
Yes, within 24 hours.
Immediate post-op, right? So immediate post-op hai, we can appreciate that there is air. Obviously, that is the post-surgical appearance. We can see some patchy post-contrast enhancement along the periphery of the lesion on the right side. And there is residual lesion is appreciable. Go to the next slide, please. Post-surgical smooth pachymeningeal enhancement, that is a normal feature post-operative. Reactive enhancement of pachymeninges, some patchy enhancement in the tumor, residual patchy enhancement, and I can appreciate the residual tumor as well. Any other images? So The cystic component is hyperintense on flare because it is kind of entrapped. There is, yeah, these are all the features, yes. Nothing else to add.
Thank you. So on histopathologies of third ventricular lesion is for astrocytoma, CNS WHO grade 4, IDH wild type on ISC, and pilocytic astrocytoma features were there. And for the temporal lesion, it was low grade astrocytoma.
Wow.
So the further management plan for this patient.
How old is he?
36.
डॉक्टर आसिम आपका सर क्या प्लान था इसको रेडिएट
So,
करेंगे जी
yeah, definitely, because there's two component in this, because this patient was initially managed somewhere else, and at that time he had this shunt and biopsy also that shows the pilocytic astrocytoma. So it was somewhere in 2023. However, since the operation, he remained on and off with a surgical colleague because sometimes he required BP shunt, sometimes BP block, and all this kind of stuff. Um, However, the patient's symptom got worse, so he ultimately had this surgery in 2025 that shows the astrocytoma high grade. So at the time of surgery, they took the biopsy from the two side. One is from the cystic lesion that have shown in the scan, and the other is the temporal part as well. So the cystic part, as mentioned, it shows astrocytoma grade 4, but the second part was shows flare changes on the MRI, shows the low-grade astrocytoma. So depending upon all these findings, we got astrocytoma grade 4. Definitely, this patient require adjuvant radiation therapy. Um, so one of the challenging things, because we have also have our histopathology colleague with us as well, because this is one of the things, because we have also seen in our institute as well, because sometimes the patient was operated on pilocytic astrocytoma. However, down the road, 2 or 3 months, the disease progresses. And when it turned out to be excised again, it again shows the high-grade astrocytoma with pyloid features. So any comment with the astrocytoma with pyloid feature versus pilocytic astrocytoma, because pilocytic astrocytoma is a pure thing. It has a benign course and indolent course that takes a lot of time actually to progress. However, the other variant, astrocytoma with pyloid features, sometimes is actually is aggressive one that require management on the light of high-grade glioma. So any comments from our histopathology colleague?
Yes, thank you for asking. Actually, the thing is that the astrocytoma with pylomyxoid features, that's known as the pylomyxoid astrocytoma, that is graded as CNS WHO grade 2. The problem with this tumor is that it has heterogeneity inside it, which I think may have contributed to this. Generally, pilocytic astrocytomas, CNSWHO grade 1s, they do not progress by themselves to grade 2 or grade 4. That's very rare for them to do. So if down the road you've had experiences like this, first you get a CNSWHO grade 1 and then suddenly it jumps to grade 2, grade 3, or grade 4 in subsequent biopsies, that's probably because the previous biopsy was not was from an area which was of low grade, right? Because these have intra tumoral heterogeneities. Your pilocytic astrocytomas are also going to show you sometimes myxoid areas, but the entire spectrum would be of CNSWHO grade 1. Pylomyxoid astrocytomas, on the other hand, would be CNSWHO grade 2. So I think that is where it goes wrong a little bit. Number 1 point. Number 2 point, such a huge jump going from grade 1 directly to grade 4. That's a huge jump now. That is something which is very concerning, that why has it happened? Because generally speaking, right now WHO does not define a categorized molecular pathway for CNS-WHO grade 1 pilocytic astrocytoma to progress to grade 4, right? I would like to add one thing. This histopathology, was it done within Aga Khan?
The first one, I don't think so.
The first one is not from here. This one is from the AQH.
Okay, because IDH wild type on IHC, basically So they did not go for molecular. They did not go for PCR, IDH1 or IDH2 on this case, right?
I don't think so in the first
No,
one,
no.
right, Dr.
Yeah.
Asim?
Yes,
Yeah.
yes.
Okay. Because if it is IDH wild type proven by PCR, it will not be astrocytoma, it will be glioblastoma. Astrocytomas are IDH mutant by definition. They can be grade 4, but they are IDH mutant. And please enlighten me on this, that if they are IDH mutant or IDH wild type, does this change the management or any drug can be added if it is IDH mutant?
So what we have seen the IDH mutant, so glioblastoma, I think now we are using it like we are using the term mostly IDH wild type WHO
Hmm.
grade 4 astrocytoma. That tells us it's more aggressive, and the survival and the response to the CCRT will not be. As a surgeon, I'm just saying, when I see IDH wild type written on the report, I know I'm dealing with more aggressive disease as compared to the IDH mutant. This is how I read it. And
So,
yes, sir. So, Dr.
no,
Asim,
I think Dr. Athar would like to say something.
Dr. Asim.
Yeah, sorry. So I think for polycystic astrocytomas, it's a completely different class of astrocytomas, and they are actually IDH wild type, as opposed to the usual astrocytomas where we are able to differentiate RDH mutants, which are usually astrocytomas grade 1, 2, or 3, or oligodendros, and RDH wild type, which are usually grade 4 glioblastomas. Classical polycystic astrocytoma is also RDH wild type. So I
Yes,
don't think
yes,
this patient
yes.
is polycytoma. I think he just had a high grade tumor, and as you rightly said, maybe it was a sampling error from the biopsy. It was from a low grade area.
Hmm.
So that's a very important point, because one of the reasons to actually present this case is again because if we look at the scans and but what the initial biopsies actually says is something different. But it should, because of the nature of the disease itself, it progresses over the period of time. That is not the usual case with the pyrocytic astrocytoma. I totally agree. I totally agree that the pyrocytic astrocytoma usually have this wild type IDH morphology, but still the prognosis, the natural course is somewhat very benign as compared to the what we are seeing in the astrocytoma and seen as W grade 4 high grade lesion. So that is the sampling error is definitely the challenge, and that's why initially that it was reported something else, like pyrocytic astrocytoma, most probably because of the sampling issues. And right now, the third ventricle lesion shows astrocytoma WHO group 4. Sometimes the tumor itself is a combination of different components. So one cannot completely exclude the pyrocytic component from the tumor itself, but definitely uh, 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 management depends upon the high grade component.
I totally agree with Dr. Zainab's point also. I also have not seen, pilocytic astrocytomas transforming from grade 1 to grade 4. I think it was a sampling error, perhaps the area where we took the sample. Agreed. So my question, Dr. Asim, to you would be like, what kind of radiation would you be considering in this case? Would it be whole brain radiation, or you're going for something else? Can you enlighten us with that? Since
As far as radiation is concerned, because it's a grade 4, so definitely the patient require radiation therapy, and also from the medical oncology point of view, the role of adjuvant chemotherapy as well. So it is not the whole brain radiation therapy. The normal recommendation or the standard practice is that you have defined your tumor volume on the images that include both the residual disease on the post-op MRI as well as the post-operative changes within your define as a cross tumor volume, and then you can define your CTV. So it is a conformal type of radiation therapy. It is not something like the whole brain radiation therapy. The challenge here would be because there is two component. One is the high grade component, and one is the flare changes that shows that low grade component. But still, because again it is only the sampling from the temporal lobe region, it is not the completely the thing that is not completely excised. One cannot actually completely exclude. So it is a conformal VMAT based radiation therapy that we usually offer in this type of patient.
okay, thank you. Dr. Manib, do you want to add something? Or
No, no, I agree with the plan, but the only thing that what we do that if the IDH status comes out to be negative on PCR, oh sorry, and ISC, we usually offer PCR. just to confirm, differentiate between astrocytoma grade 4 and GBM.
So
In terms
totally
of
agree.
management, I agree with Dr. Asim.
So that's why whenever
In
we
terms of
have
management, I totally agree with Dr. Asim.
So that's why whenever we have a confusion regarding the IDH status on the ISC, it is our common practice that we can proceed with the molecular studies rather than just focusing on the ISC.
In terms of prognosis, I think there is a slight difference after the WHO classification came out. Otherwise, management-wise, it remains the radiation doses and
Yeah,
chemotherapy.
there's a significant difference, as well as the management perspective as well.
And the management is different for IDH wild type and IDH mutant also, Dr. Asim?
So currently, the management, if we are talking about the high-grade glioma, it has an effect on the prognosis. But as far as the management is concerned, from the radiation perspective, I don't think so. There is a high-grade tumor, it is somewhat different. The only thing is that because though we have a limitation, but still that, for example, if the tumor is a low-grade tumor and it turned out to be IDH wild type, morphologically is something different and molecular is something different. In that scenario, definitely the IDH has a very strong impact in terms of management plan. But if you're talking about the high-grade glioma, it has a prognostic impact, but not from management point of view. From the, whether we are talking about the IDH mutant or IDH wild type, the radiation dose would be the same.
Right. Perfect. Thank you. So let's move to the third case. Dr. Yamna, have you joined us? I can't see Dr. Yamna.
So,
Yes, now. Ji. Okay. So yeah, Dr. Yamna. So
uh,
I'll be sharing my screen. Please present your case.
okay, I'll be sharing the case of a 37-year-old Asian male who presented to us with headache and blurring of vision back then in May 2025. He had those complaints for the last 5 months, and our diagnosis was a solid cystic cellular and supracellular mass. We offered him an endoscopic endonasal transsphenoidal resection of that lesion in May 2025. And histopathology turned out to be a WHO grade 1 craniopharyngioma with no evidence of granulomas or malignancy. Okay.
We can ask Dr. Shumaila about the radiology. Dr. Shumaila, our apologies. We have limited images and sequences here, but would like to hear from you.
Thank you. So we only have axial images. So I would suggest the people who bring case that in case of cellular and supracellular masses, try to bring the midline images like coronal and sagittal, because on axial there are multiple flow-related artifacts in the region of cellular and supracellular cisterns. So delineating the pathology becomes very tricky on these, that what is the pathology and what is an artifact. So that's my advice. If you can try to bring that. I can appreciate that there is a heterogeneous signal intensity area in the region or in the supracellular region. And if you go back to the next slide, actually, it is difficult to appreciate pituitary on the axial images. So in the next slide, which are probably these are not post contrast, right? These are flare images. These are flare images because the gray-white matter differentiation says that these are flare images. So there is, again, a flare hyperintense lesion in the region of sphenoid sinus and supracellular region. We do not have any sagittal images, so picking up a pathology on these is not possible.
Yeah, so apologies for that. I think there was some system error. We could not download more images, so that's why we have very limited images. So he underwent a surgery. Yes, Dr. Yamna, do you want to add anything? Okay, so this is, I think, the post-op scan in the June.
Okay, so in the post-op scan, I can see that there is some enhancement in the supracellular region. If you look at the last image, the third image in the row, we can see that there is normal pituitary gland. We can see bilateral normal ICA, cavernous sinuses, and above the pituitary gland, I can see that there is some heterogeneously enhancing solid and cystic area. So this is probably a residual lesion, post-op residual lesion. And since we already know on histopathology, this is a craniopharyngioma. So this is a residual craniopharyngioma lying in the suprasellar region. The same, it is better seen on post-contrast images. The same is seen on T2 weighted images. It is causing some compression on the third ventricle. And that's it. That's all I can see. There is hydrocephalus. The temporal horns are prominent bilaterally.
And this scan is in November. So
the last scan was from June, and this is a new scan from November, right?
I
So
think,
here the enhancement is more conspicuous. The
yeah.
enhancement is more clearly visible. It is on the left of midline, and the post-operative changes have subsided. There is a residual enhancing solid component with an adjacent cystic component in the suprasellar region, adjacent to left MCA. And these are probably plain T1 weighted images.
Yeah.
There's a small left suprasellar lesion, which was showing enhancement. It is the same area which we could see on axial images as enhancing area. It is on the left of midline, adjacent to left MCA. These are post-contrast even weighted sagittal images, and this enhancing. We can see that the pituitary gland in the first image, we can appreciate that the pituitary gland is lying in sella. The sella is not expanded. This is a suprasellar lesion adjacent to optic chiasma. It is showing enhancement and it is off midline. These are FLAIR axial images, and on FLAIR we can see that this is a FLAIR, slightly hyperintense on FLAIR images as well. And there is hydrocephalus, and there is residual craniopharyngioma visible.
Right. Thank you, Dr. Shumaila. So, question to the board is, the patient after the surgery is asymptomatic now. His vision has significantly improved. He has no complaints of headaches or whatsoever. If you look at the scan, there is hydrocephalus, but he's asymptomatic. So I was wondering if we can offer him radiation. So I think Dr. Asim, please enlighten us if he has cranium. Yes.
So the two things. What is it about his hormonal status?
Yamuna, do we have the reports with us? He is with the endocrinologist review, and he's doing well on that. I do not know if we have right now all the labs with us.
Because this in decision making process, this is one of the important factor, because depending upon the functional status of the pituitary gland hormones, I mean, that management would, it also has contributed in the decision making process. Because dealing with the craniopharyngioma itself, my second question from you, Dr. Hassan, is that regarding the surgical excision, is it possible we can actually remove the remaining portion? Because for craniopharyngioma, if it is resectable and completely, then definitely the surgery would be the preferred option, and usually it is not recommended to add a region in the context of cross-total resection. You can add anything in the adjuvant setting. However, if there is a residual disease and the resection is not possible, then definitely there is a role of radiation therapy over there.
Right. So I said, if you look at that enhancing component, that is suprasellar, and it's close to the MCA. It looks like it's kind of abetting it. So I think because of surgical morbidity, I would be more inclined towards radiation. That is the thing, in my opinion. And it will require most probably would require a transcranial approach, not the endonasal approach. So I think that is one thing that we are struggling with. And the patient is clinically, he's doing excellent. Yes, Dr. Atif.
Yes, I agree with Dr. Asim's point that really you want to get maximal debulking and surgical removal and try and avoid radiotherapy in a low-grade lesion like craniopharyngioma. But this patient has already had 2 surgeries, and I think I agree that if we can remove it, third time we should, but given that it is going to be morbid, I think he'll need radiotherapy anyway, because even if you remove it, there'll be very high risk of local recurrence. I think this patient needs radiation anyway, whether you remove the residual disease or not, he'll be at high risk of local recurrence.
So
And
he
obviously, the
underwent
surgical
only one
morbidity is
surgery.
quite high.
Right, sir.
I think, so okay. Because I thought there was a surgery last year, and there was a post-op scan up in June. Is that not right?
Yes, sir.
It's only one surgery, is it?
Yes. It's on. He only underwent one surgery in May.
Okay, right. Okay. Yeah. So I think Dr. Azim's point is very valid that if you can remove it, then fine. But if the surgical morbidity is going to be quite high, then radiotherapy would be very.
In my humble opinion, the surgical morbidity will be a little bit, kind of that might disturb us because of the location and its association with the neurovascular structure. If I have studied the radiology, and then so that's why I did not offer him surgery. And one of the other thing that he was never given any kind of radiation. So for the cystic component, if in future after even radiation, if that cystic component is causing any compression, I was thinking maybe inserting an Ommaya reservoir. But again, that would depend upon how he's doing in the future. Rather than going for radical resection, I think for the cystic component, Ommaya might be more helpful.
So the important thing is that because both option is valid, resection versus a pool of radiation therapy, I think that will require a discussion with the patient itself regarding what is their opinion, because both have its own advantages and both have their own limitation. So need to be discussed with the family. So if technically it is a difficult one or may lead to a lot of the morbidity that is beyond expectation, then definitely radiation therapy is required, because it will not treat, because this is a time because the bulk is small. So I would more incline towards if we are going for the radiation therapy right now, rather than if we are waiting, just put the patient on patient ward, and if there is a progression, then one can consider. But because of the reason of asking the pituitary function initially, because if we are going for the radiation therapy, looking at this relationship with the optic chiasm and the surrounding structure, definitely all this thing needs to be incorporated in the management plan as well, in the radiation plan as well. So that's why it is important to have all this discussion with the family as well and the patient as well before proceeding with any of the treatment option. Dr. Muni, would you like to add something, or Dr. Athar?
No, I agree, Dr.
Dr. Munib.
Yeah, I agree with both the Dr. Asim.
Perfect. Thank you. ठीक है सर, फिर हम oncologist के पास इनको भेजते हैं, and then we'll discuss the options and we'll see the pituitary functions as well.
Yes. And what about his vision?
And we have to counsel him about it.
Vision is great, sir. Vision is better than what I was expecting post-op. Like he came to my office
Also
and he could
discussion
not
about
see
the
my
long-term
face.
endocrine
He couldn't.
dysfunction.
Sorry, Dr. Munib.
I think there is problem with my mic. Sorry. I just want to add one point. Can you hear me?
Ji, sir.
We just have to counsel the patient about the long-term side effect that could be the endocrine dysfunction after radiation. We have to counsel about this.
Okay. ठीक. Yes, sir. So, Dr. Asim, to answer your point, his vision is good, has improved significantly, and he's a welder by profession. He has started working, and he's fine. Yes.
Okay.
All right, sir. So, if no further questions, comments, I will end our today's session. Thank you very much. Thank you all for joining.